Good afternoon from CSG headquarters in Lexington, Kentucky. I'm Brandy Wisman, a policy analyst at the Council of State Governments, and I currently staff the State Health Systems Return on Investment Subcommittee of CSG's Healthy States National Task Force. One of the policy areas the subcommittee has focused on is telehealth in rural communities. Josh Seidemann is here to tell us more about it. Joshua Seidemann is Vice President of Policy of NTCA, the Rural Broadband Association. Josh focuses on federal regulatory issues as well as technology and market trends affecting the rural telecom industry. He supports research initiatives and programming for smart rural communities, a network of rural communities leveraging broadband-enabled applications to support broadband-enabled agriculture, education, healthcare, transportation, and other industries. He is a regular contributor to the NTCA blog and other media on emerging tech and other issues. Josh holds undergraduate and law degrees from Yeshiva University and is admitted to practice in New Jersey, New York, and the District of Columbia. So Josh, can you just tell us a little bit about yourself and what you do?
Sure. So as you mentioned, I work with NTCA, the Rural Broadband Association. NTCA represents about 850 small, locally operated, facilities-based broadband providers. And what that means is these are small companies serving communities in rural America of maybe 5,000 or 10,000 or 20,000 people. But these are areas where the Bell Company did not deploy a telephone network in the early part of the 20th century because there was no business case to go there. The Bell Company focused on larger cities like Columbus or Indianapolis or even New York City or San Francisco. Our members began either as community cooperatives or small family or small commercially owned companies providing telephone. They are now all broadband deployed. And I think our latest survey data shows that more than 2/3 of our members can deliver gigabit broadband service to more than 2/3 of their customers. So that is who our members are. On their behalf, NTCA as a trade association works with our members and represents them before the Federal Communications Commission. We work with them on Capitol Hill in terms of emerging legislation that may affect their industry. We work with the U.S. Department of Agriculture on rural utility service and other programs aimed at developing rural communications networks. And we also provide, in addition to those kind of Washington-centric services, we also provide education and training for our members' staff and workforces as well.
Fantastic. So as we kind of talk about your members and what they do, when we talk about broadband-enabled healthcare, what do you mean by that?
Well, broadband-enabled healthcare is probably one of the most universally accessible ideas that we promote at NTCA. We have a program called Smart Rural Community. And this program promotes not just the deployment of broadband networks, but the collaborative use of those networks by our broadband providing members and other local leaders in their communities, whether that be a school superintendent or public safety or healthcare organizations. And what we find is that, as time goes on, more and more critical elements of rural life, if not all life, are really becoming broadband dependent and relying on Internet of Things technologies. When we talk about telehealth and telemedicine, these terms are frequently used interchangeably. For those who want to get a little bit more specific, telehealth may be used to refer to ongoing healthcare monitoring, kind of analogous to your annual checkup with your internist or perhaps your twice a year visit to the dentist. Some people refer to telehealth as that, and some people refer to telemedicine as there's a condition that we need to treat, whether that's an acute condition or a chronic condition. But by and large, telehealth and telemedicine refer to the use of some type of broadband-enabled communications technology to bring a doctor and their patient closer to each other and to facilitate treatment without needing to be in the same room.
Interesting. So as we talk kind of further about rural communities and the role that telehealth can play in them, what are some of the potential barriers to implementing telehealth in those communities?
Well, there are certainly potential barriers to telehealth, and then, we'll talk about, we're going to talk about the potential barriers, and then we can spend a little bit of time about talking why it's so important to overcome those barriers. I would say that there are probably 3 barriers to telehealth, and these may be, they may be perceived with a greater intensity, perhaps, or a greater need in rural areas. The first potential barrier is broadband deployment and broadband adoption. If you go into a large or medium-sized city with houses on, say, a quarter-acre plot of land, or perhaps an apartment building downtown, you can serve hundreds, if not thousands, of customers by putting down just a half a mile of a facility. When you go out to rural America, and the population density in our member service areas is, I think it's across their total service area, it's maybe 1.8 person per square mile. And that includes farmland and wilderness. But when you get down to the town center, it still might be 6 or 7 people per square mile. The capital expense of deploying that network is terribly expensive. Our members, as I mentioned, are locally operated, so they've got, whether they're cooperatives or family or locally owned businesses, they've got a commitment to getting the job done in their community, and they do it, and that's really seen in their broadband deployment rates. So certainly in our member service areas, we do see that broadband deployment there, and I think that's kind of barrier number 1 that gets moved out of the way for telehealth. And then barrier number 2 and number 3, 2 sides of the same coin, is patient willingness to adopt telehealth and to use it, and then physician acceptance of the technology. Now, physician perceptions are changing. Nielsen did a survey several years ago, and it really took the temperature, so to speak, of doctors and how they felt about telehealth, and we see positive trends toward that. We see from studies in terms of consumers, millennials are really leading the way with telehealth usage. 74% of 18 to 34-year-olds and 72% of 35 to 44-year-olds say that they are willing to use the technology. I think that reflects probably greater comfort with technology among those age groups and demographics. And certainly when we move further up the age line, senior citizens might be a little bit more reluctant to employ the technology. But we can talk about in a few minutes why telehealth for senior citizens may actually be a more important initiative than getting the younger people on board.
Sure. So now might be a good time to kind of expand on that, why it's important for seniors to get involved in telehealth and how it can be beneficial.
Well, this, and I think this goes across both rural and urban areas. I can certainly share with you, later on in the conversation, some numbers related to the benefits of deploying rural telehealth generally. But if we take a look, let's take a rural community, for example, that really doesn't have a strong public transportation network. Now, if you have a senior citizen who is suffering from a chronic condition, who really does need to be seen on a weekly or bi-weekly basis, if they are in a community that has bus service, and if the senior citizen is able and is ambulatory and can get over to the bus stop, or still drives, they really don't have much of a problem. When we get out to many rural areas, there really is not a comprehensive public transportation network like you do see in larger or medium-sized cities. And at that point, and I've spoken with some of our NTCA members, and I've asked them, how do the elderly or the non-ambulatory get around? And they say, well, we don't have a bus system, but we do have volunteers. We have a social services organization. We have the Lions Club. We have the Kiwanis. We have the church. They will provide transportation to senior citizens. The reason why telehealth can really benefit senior citizens is when you remove that disincentive of having to leave my home and rely on someone for a ride or get out of the house and go to the doctor, as important as it really is to get out, you might encourage greater patient compliance with medical directives if I can check in and see my doctor each week to talk about my diabetes or my COPD in a quick 15-minute check-in session over my iPad. Suddenly, that 3-hour excursion to get dressed, to get into the car, to go down to the doctor, to wait, to sign in, to be seen by the doctor, to go home, that gets turned into a 15 or 30-minute patient-physician encounter. That's one. Two, that increase in patient-physician encounters and the use of broadband through teleconferencing can do a lot to also mitigate against the problems of senior isolation. And isolation can lead to depression, and that can lead to all sorts of follow-on health problems as well. Now, again, we're saying, well, you're going to stay in your home and see the doctor from your home. Maybe that introduces some sort of self-selected isolation because I'm not getting out to see other people. But I think by and large, broadband, whether for what we would call a physical health condition or for mental health conditions, can be exceedingly important for the senior citizens.
So it sounds like one of the potential benefits is really kind of opening up access to physicians that may be difficult otherwise. Can you talk a little bit more about those kind of quantifiable and non-quantifiable benefits of expanding telehealth?
Sure. And again, let's think about this in context, because suddenly, we're all in cities, right? You're in Lexington, and I'm just outside of DC in Maryland, and I grew up in Central Ohio, so we had doctors, we had nurses, we had physical therapists and mental health therapists, really within the city. If you take a look at some of the numbers that we can develop from various associations and federal agencies, about 25 to 30% of the U.S. population lives in rural areas, but only 10% of our nation's physicians live in rural areas. Rural areas have 70% fewer specialists per 100,000 people than urban areas. So it's not just lack of access to an internist. It might be lack of access to an oncologist. I traveled was in Wyoming a few years ago and spoke with someone. They do not have an orthodontist in town. The orthodontist comes to their town once a week, and you make your appointment with all the other patients. I'm sorry, actually I take that back. Yeah, once a week. If your child's wire breaks, you have a choice. You wait a few days until you can get another appointment and hope that the orthodontist can see you then, or you get in the car and you travel 2 hours over to where the orthodontist lives. So that's really one of the things that we're looking at is physician shortage in rural America. Now, we layer onto that on average, and again, average means all the collected data, and there are outliers at each side, but on average, people in rural America are older, less wealthy, and less healthy than their urban counterparts. Diabetes, incidences of diabetes in rural America is 17% higher than in urban areas. Hypertension, obesity, cancer, all have higher rates in rural America. So there are higher incidences of chronic health conditions and fewer physicians to serve them. And then we take a look at emergency and acute medical conditions, and suddenly, God forbid, there's a car accident, and I'm not 20 minutes away from a hospital. I'm an hour from the hospital. So that is where telemedicine really can come in to help. And these are some of the numbers that NTCA developed. I mentioned that we have our Smart Rural Community Program, and we focus on a few initiatives, and some of them are education. If you take a rural area and you look at per facility, and you figure that sometimes if someone has to go to the doctor, it's going to be doctor's an hour away, I've got to take a half a day off of work. If I can engage a visit by telemedicine, what our numbers developed was, on average, per facility, telemedicine would be able to save a rural area close to $6,000 a year. Lost wages per facility would reach about $3,500 a year. Hospital costs would go down $20,000 a year, and again, this is per facility. And there would be increased local revenues for lab work and pharmacies ranging from $10,000 to $40,000 a year. So we see that these numbers begin to make sense. We have this intuitive notion that telemedicine is good, and then the numbers begin to back it up as well.
It sounds like there are quite a few kind of positive ripple effects that come from utilizing telehealth. So my last question will be, can you share some examples of just a few successful telehealth partnerships?
Yeah. And again, this begins to circle back to where we started with our conversation in terms of NTCA members being locally operated, and they know their communities. They're not a faceless Wall Street corporation that is, pouring investments into the big city and, doesn't really need to do much in the smaller town. Our members are frequently the largest employers in their communities. So I'll share with you really what some of our members have done. We have a company in South Dakota. They use broadband to communicate with robotic devices that can serve as health assistants for the elderly. These devices are used by health providers to administer tests and help deliver medication and to report data to an area hospital over a fiber network connection. We have a number of our members are supporting hospitals with the transfer of electronic health records. I think probably one of the best stories I've heard, and we've got a couple of companies that have done this, actually both in Georgia, interestingly enough. They have created within their public schools what we call a connected healthcare cart. And one of these schools actually serves an area where I think a third of the students are eligible for free or reduced lunches under federal programs. So this is an area where parents don't have a lot of money to begin with and can't really afford to take time off from work. What this connected healthcare cart does is it enables a nurse to communicate with a physician who is about 40 or 50 miles away in a regional healthcare center. And what that does is if a student comes to the nurse and says, I don't feel well, the nurse can evaluate the student. And if the nurse needs a physician's opinion, that physician who may be 40 or 50 miles away can use this connected healthcare cart that relies upon the broadband technology to listen to the student's heart, to take a look inside the student's throat or in his ears. And the doctor can tell the student, okay, something, this looks to be like a virus or a common cold. We're going to get you a prescription. You'll go home and rest up for a couple of days and you'll be fine and go back to school. That has just saved mom and dad from having to take the child 40 miles away and half a day of work to go over to the doctor's office. But the doctor can also then spot something where the doctor can tell the student, I think you need to come in tomorrow and bring mom with you. We need to see you in person. And that ensures that students who do need to be seen by a physician can be seen by a physician. I would say that we would call this the meaningful use of technology. And we get a lot of questions sometimes from policymakers, broadband in rural America, that's so someone can stream Netflix or game. And we like to say, no, it's the return on investment on that broadband facility is every elderly patient was able to monitor her diabetes. It was every veteran who was able to engage the VA's telehealth services through a broadband connection. It's every student or worker who was able to stay in school and stay on the job because they could quite efficiently visit with a doctor and get the right treatment over the wires.
Well, Josh, I want to thank you so much for joining us today and sharing both your knowledge and your perspective on this. It will greatly help to inform the work as we move forward on our subcommittee and task force this year. So again, thank you.
Thank you so much.